Hi, everyone. I'm Tala Elia, and I'm also from Massachusetts, but from the other side of the state than Liz. And just to give you a little context of our institution, I'm from the University of Massachusetts Bay State Medical Center, and we're in Western Massachusetts, and we're actually the only tertiary care center, level 1 trauma center, and pediatric hospital in our region in the western side of the state. So we have quite a big catchment area and relatively high acuity. We see about 122,000 patient visits a year, and for our physician staff, we have 50 attending physicians, 9 fellows, and 42 residents. In addition to that, we have our AP staff. We have 19 advanced practitioners that work in our emergency department. It's a mix of physician assistants and nurse practitioners, though predominantly physician assistants. And they actually work in all areas of our emergency department, both in the main ED and the pediatric emergency department, though a lot of their shifts are focused in the moderate and lower acuity areas, just in terms of number of shifts per day. So we have a moderate acuity area that sees mostly a large number of ESI 3s, but also sees ESI 2s, as well as some lower acuity patients, really everything short of resuscitations, though I won't say a resuscitation doesn't sneak in there occasionally. And that pod is staffed by an attending and 2 APs. We work as a team. They're sitting side by side with the attending, and the attending is available to precept those patients. We also have a fast track process up front that we've started within the last couple years. It runs Monday through Friday. And when we started it, it was initially staffed solely by an AP for 9 hours a day. And they were seeing really low acuity ESI level 4s and 5s. And as we've sort of looked into this process and advanced it more, we've started to transition to what we're calling an enhanced fast track. We're actually adding a physician to that team, and that team of a physician and an AP is out front seeing not only the 4s and 5s, but the vertical 3s, those sort of lower acuity ESI 3s. We're sort of moving to that model, and within the next couple months, actually, we'll be solely doing the enhanced fast track, where it's, again, a physician and an AP together as a team rather than an AP working solely out front. In addition to those areas, those are many of the shifts the APs work, but they also work daily shifts in our main ED, seeing where our high acuity patients are, and as well as pediatrics. In those areas, they work as, again, part of the team. It's an attending physician, as well as a team that consists of senior and junior EM residents, sometimes off-service residents, and advanced practitioners. And this is really, they do staff overnight as well as day shifts. And this has really been beneficial from both ends because our advanced practitioners love working these shifts. They really love seeing the high acuity. They love getting that exposure to those patients. But it's also been really beneficial from us from a resident teaching standpoint because it's allowed us to structure and restructure our resident staffing in a way that we can actually at times pull residents off some of those teams and schedule them instead one-on-one with a swing attending where they're still seeing the high acuity patients, but they have the advantage of that one-on-one teaching, those one-on-one teaching shifts. So it's really been a benefit from both areas. So we also, with our staff and with our expansion of our program, we're looking to expand a bit more, and we do have some attrition and needing to hire new staff. So we've looked a lot into our orientation process and really formalized the process. We also hire a fair amount of new grads, and so having a new grad come in, we really need to look carefully at how we onboard people and how that orientation process goes on. So we start off with a couple what we call mentoring shifts. They have about 2 shifts where they come in, they're just learning the system, they're learning the charting, how to log in, how to see patients, where things are. And they're seeing a few patients during those shifts, but they're paired one-on-one with an experienced AP that doesn't have any other clinical responsibilities at that time. They're coming in solely to mentor that person. So we start off with a couple of those shifts, and then we go into a 6-week orientation period, at which point the new hire is not part of the schedule in terms of minimal staffing. They're an extra person on that shift. So they can really take that time to build their clinical knowledge and not really feel the pressure of just having to move patients through. And during this whole orientation period, all the patients are seen and precepted by the attending, and they present directly to the attending. I will say we do have rough timelines for these orientation periods, which I'm talking about a little bit, but our graduation process from one step to another is very competency-based. So we acknowledge from the beginning that we anticipate the initial orientation period to be 6 weeks, but depending on their experience or how they're progressing, we do adjust that. And we solicit feedback regularly, and that's how we address that competency-based piece if they're ready to move on to the next step. We send out evaluation forms to the attendings after each shift and try to get feedback and meet regularly with the APs to go through what's working, what's not, what areas they need to work on. After that initial orientation period, we do put them on the schedule where they're part of minimal staffing, but they stay in that moderate acuity area. And that lasts for about 3 to 6 months, depending on how that person is progressing, before we start putting them in the high acuity area. During the first year, for new grad, we do ask that all their patients are seen and precepted by attendings, even though they've graduated to the next step where they're in the high acuity areas as well. We also, the last place we actually put our APs is in the fast track. That's the last place they'll be placed on the schedule because geographically, though they have a supervising attendant, they're geographically further from the attending and sort of working in isolation, and they need to know how to pick out the sick patients from the barrage of ESI 4s and 5s that do sneak in. We also have ongoing education because though they have this education period, recognize that they continue to learn and grow and need to expand their knowledge. So we have a monthly education curriculum that's rolled into our monthly staff meetings. We cover core emergency medicine topics, but then also when we identify areas of opportunities or areas where we can expand on growth, we incorporate those topics. New and emerging topics we tend to incorporate in this curriculum, like opiate prescribing and new narcotic guidelines. Once a year, we have an annual AP day where the tables are flipped a little bit and the residents actually cover the department, cover the AP shifts, and we spend a day of simulation, workshops, some team building exercises, and it's really a day that people really look forward to. We get a lot of education in there. And of course, we have our resident conferences, our journal clubs, and those are also open to our advanced practitioners. They work side by side with the residents on a regular basis, and we open the educational opportunities to them as well. Our supervision is a little bit different than MGH in that though our APs function a lot like residents and are integrated and treated during the shift a lot similar to residents, we do have situations in which we allow our APs after that orientation period, after they've been practicing for about a year or so, to treat and release some patients without having them been precepted by the attending. And I know some institutions do this on an ESI basis level where 4s and 5s can be seen and treated and released by an AP. We actually do a little bit differently. We do it complaint-based. So we actually have a couple of guidelines. We have a treat and release policy that lists complaints. We do it sort of chief complaint-based, of which can be seen and released by an AP. The chart is later reviewed by a physician within 72 hours, but at the time they can be seen and released. And then we have a sort of partner document that's our physician consultation guidelines, and these are the patients that need to be precepted by an attending. So the treat and release are simple things like pharyngitis, simple lacerations, ankle sprains, some musculoskeletal complaints, where the physician consultation guidelines encompass things like anyone that needs a CT scan, anyone needs that specialty consultation or admission to the hospital, and they're fairly sort of exhaustive lists. We have started a PA residency. We're about to start our 5th residency class in our PA residency, and this has really been a big success for us. It's a 1-year residency. We take 2 residents a year, and when we started this residency, we thought, we don't need to reinvent the wheel. We have a training program. We know how to train. As I said, we know how to train emergency medicine physicians, and we can take those skills and that infrastructure that we have and give some specialty training to these new grads that are coming to us. We integrate the PA residencies very much with our physician residencies, and they very much function like an intern for that year of their residency. They start off in July with the interns and do a month of didactic training, workshops, simulation, and then they spend the vast majority of the rest of their time in the ED, though they have some elective time and some other rotations built into there. They have ultrasound time, anesthesia time, so they can get procedure skills. And then their elective time is really tailored to what that particular PA needs to work on. So we've had people do ICU, neurology, sports medicine, more procedure time. When they're doing their residency, they spend most of their time in the higher acuity area because we feel like that's where they really need to build their skills. And when they're in that high acuity area for the entirety of the year, they are always scheduled as an extra person. So again, they can really work on that clinical fund of knowledge and build a good basis. Throughout the year, we also require that all their patients are seen by an attending so that they can have that direct feedback and as well as supervision. And in the second half of the year, they have some of their shifts in that moderate acuity area as part of minimal staffing so they can work on their efficiency. And we've really had a lot of success with this. As we were about to start our 5th year class, we have our 2 current residents are staying on with us, and I'm asked almost daily, have they signed their contract letter yet? Are they staying? Because people are really excited to have them stay because they're tested and they know that they're doing well clinically. And I think of our graduates, we've had 3 that have stayed on with us, and the others have been very well received elsewhere. So with that, my time's up, and I'll pass it on.